So my aims of today is hopefully to dispel some myths, give you more knowledge about Parkinson's as well. And so the next time I'm doing this, you'll just hit me with all the answers. How many people have dealt with Parkinson's patients? Quite a good number. Good. That's fine, so tell me what Parkinson's is. What's Parkinson's? Lack of dopamine, wonderful. Where? In the brain, yeah. It's progressive, I heard somebody, yeah, it's progressive. It's a neurological condition. 1 in every 500 people have Parkinson's. Majority are diagnosed over 50, with about 5 to 10% ending up in care homes. And that number is increasing as we get older, and the elderly population, as you know, is increasing. It's progressive and comes in 4 stages. Although recent research has shown there's a pre-stage as well. So there's a pre-diagnosis stage, there's a diagnosis stage, there's a maintenance stage, there's a complex stage, palliative stage. And that's probably where the care home aspect would come into play there. It fluctuates from day to day, so no day's the same with a patient with Parkinson's. It fluctuates from hour to hour. It's very individual and no patient is exactly the same. So if you've got more than one patient with Parkinson's, they can be completely different because it's an umbrella of conditions. So everybody is different. And there's no cure. And as I explained, it comes in different stages. So when a patient comes in and gets diagnosed, yes, it's a shock. So a lot of it is education, support. It's early referral to the multidisciplinary teams, the physios, OT, speech and language, because it's a relearning technique that has to happen. It's quite good. You start them on their drugs and you get a kind of a maintenance period with everything's all hunky-dory. You usually get about 2 to 5 years out of that maintenance period, because remember, it continues to progress. You continue to lose the dopamine, and therefore what happens is we continually top up the medication. And then we add medication, then we get polypharmacy of different medications, and it gets more complex. Then, unfortunately, you get into the progression of the illness along with the side effects of the medication, and therefore what happens is you get to the palliative stage where you're thinking, is the medication doing more damage? And it outweighs the benefits, so therefore you get into the palliative stage. Signs and symptoms of Parkinson's. It's a slowness of movement. You might hear the word bradykinesia. So it's a slowness of movement. And what happens is, as you see the Parkinson's patient, they're very slow. You have the stoop posture, and they tend to go forward. That's why I've got a radio mic, because I'm very... it's a movement disorder, so I move about. So what happens is, there's a slowness of movement with people with Parkinson's. Everything slows down. Why does it slow down? Yeah, the dopamine's depleted, and therefore the signals aren't getting through. So what happens is this dopamine is the accelerator. We're all sitting here with our dopamine levels hopefully all right, but I hate to tell you, as we get older, they do deplete. Why somebody gets Parkinson's, I don't know, because it's supposed to last us our lifetime. But we all automatically lose dopamine. But what the dopamine does, it controls the automatic features that we take for granted. So me actually standing here and walking across the room and talking to you at the same time, I'm not thinking about it, I'm just doing it. Or somebody with Parkinson's who hasn't got that automatic function and is now in manual control. Can't multitask like that. They have to think about then putting one foot in front of the other, because they can't talk and walk. Does that make sense? Right? So the automatic switch is off and they're in manual control. So the simple task of actually walking has to just concentrate on walking. So if you've got a patient who you're walking along the corridor and having a nice wee chat to, what are you doing wrong? Distracting them, because they have to put one foot in front of the other. And what happens is this, what I'm doing here, automatic movement. I'm using my voice, I'm projecting my voice with the help of this, of course. But also what I'm doing, I'm using body language. I'm walking about as well. That's lost in Parkinson's because it's automatic. We don't do it. So you'll get somebody with Parkinson's just talking like this. So they don't use this movement. Okay? And that's why you'll get the loss of the facial expression, because they don't use expression. Right? And the tone was very monotoned. Very slow and monotoned. So you don't get that different accents in their communication. So it reduces the size of the movements because the automatic step forward isn't there, so they have to think about it. So it's the shuffly step. Movements. Upper movements are slower. Dexterity, coordination, sequencing, and how to get dressed is affected as well. So it's all of that is affected. Parkinson's affects everything, the whole body. They get stiffness, and that stiffness is like a cogwheeling effect, a rigidity, so it looks like a cogwheel sometimes when you move their arms. Parkinson's always starts in the upper body, and it always starts on the one side. It will eventually go to the other side. But it tends to start in the upper body first. That's where it starts. If everything's fine in the upper body and they're doing body language and moving their arms, but they're shuffling along, that's a red flag that it's not what we call true Parkinson's. Yes, they look Parkinsonian, but it might be a vascular Parkinson's, where it's the circulation in the brain that's causing the symptoms as well. So you've got to look at everything when you think your patient's got Parkinson's. Tremor. Not everybody that has Parkinson's has a tremor. About a third of the patients don't have a tremor as well. But then in saying that, not everybody with a tremor has Parkinson's. So be very aware, there's a distinctive tremor in Parkinson's, and I'm sure you've seen it, the wee hand shaking. Right, it can go to the legs, it can go to the head, but it's a distinctive tremor, okay? We call it pill-rolling tremor. And it's there when they're at rest, when they're watching the television or distracted. But when they go to do something, the tremor goes away. It will come back if they're then thinking of something else. It will come back. But the type of tremor, which we call essentially a tremor, is somebody that would pick up an item and it's straight away, and the cup's going. That's different and will not respond to any Parkinson's medication as well. So it's a distinctive tremor. Altered posture is also quite common as well, and difficulties with balance. Does that seem like a kind of a picture painted of people that you've seen with Parkinson's? Yeah. So there we are. It's learned voluntary action. So how can you help? If a patient is trying to get up from a chair, you're multitasking. So when you get up from a chair, you automatically stand up and walk off. Okay? So you're using the top part of your body, you're using the bottom half of your body. Yeah? Is that multitasking? So break the task down when you're helping somebody off a chair. Don't pull them up. Encourage them to break the task down, move their bottom to the edge, fix their feet. Then, so it's one thing at a time. Does that make sense? Yeah? One way I explain it to some of my patients is that if there's any drivers in the room, do you remember the first time you actually went for your driving lesson and sat behind a wheel of a car? And although it's a different pathway, it kind of explains it for people. And they tell you to do clutch, signal, mirror, manoeuvre, release the handbrake, biting point, turn, look at your blind spot, drive off. Yeah, do you remember that? And you went like that all at the same time? And you kind of broke the task down, did it slowly, did it and thought about it until you learnt it. What it'll be like now? Sometimes you can get A to B without even thinking about it. Am I correct? So go back to the pathway that I want to talk about, and it's when the wee toddler's learning to walk, and they start walking, and then before you know it, they're not thinking about putting one foot in front of the other. What they're thinking about is what next they can destroy. And this takes care of itself because I'm ready to cause havoc. It's a learned behaviour. That's gone in Parkinson's. So they have to think about walking in each step as well. It's the same with the speech, where you find speech is difficult as well. The toddler, one word at a time, then before you know it, you think, oh, that's cute, and you think, oh, I wish they were talking in sentences and could let us know, and then you're wanting them to be quiet. Because it becomes automatic, and they're on a roll, right? And that's when you get, what's that for? Why are you doing that? What's that? You know, and you're thinking, why did I wish that? Yeah? It's gone in Parkinson's, and they have to think about each word after the other. Freezing. Anybody seen anybody freezing with Parkinson's? Why do they freeze? Why would you think somebody freezes? Any ideas? Nobody brave? Right. I'm misbehaving this woman a heart attack because I keep moving about. But what it is as you're walking and they come to something like that, the brain registers a different carpet, different pattern. So it goes, oh, there's a different pattern. And that happens. So they have to restart the engine and think, okay, big step over it. It's as if the engine's just shut down and it's said, whoa, signal's going. It's about restarting the signals again. Turning is notorious. When we go to turn, we automatically turn like that. But somebody with Parkinson's who turns like that will go, yeah? Have you seen that? Mm-hmm. Because you're trying to do top and bottom. What to do is then bottom, take control and turn with the bottom. Just use the legs and march it round. Now that's very good in a confined space where you're in the bathrooms and you're asking them to turn. Just step it round. Don't try and help them round because that's all you'll get. Right? They'll fall on you, they'll fall, get anxious, make things worse, takes you longer, it's a nightmare. Just say, well, why don't we step it round? March. That's all they're doing, that's just one command, and just march. Does that make sense? Doorways, they'll freeze, confined space. So if they're freezing, there's usually a reason why. The coping techniques I've used here is sometimes if you're walking with a patient and they do freeze, I'll say to them, step over my foot, give them a visual cue, and that starts the engine again. Right? Or a walking stick, put down, step over the walking stick. Okay? I have a lady who freezes during the night when she goes to go up to the toilet and she can't make it. So what she's got is strips from her bed of tape, and she goes from one strip of tape to the other and is able to walk before she was crawling, because that's her visual cue. Does that make? Yeah. So if that works, find something that works. How many times have you seen a Parkinson's patient who's really quite bad in the morning, but in the afternoon it's amazing to become a different person, they're really mobile, but you've helped them get dressed in the morning and they've needed a wee hand, but in the afternoon, you know, they're fine. Anybody? Yeah, because it fluctuates. But also the fact is, if they've had all night and they're not medicated, and then they start the medication in the morning with a dopamine that you're replacing, they are going to be bad in the morning. You know, so we don't want to hear, she made me dress her this morning. Look at her now. The reason is she needs you to help her dress in the morning because she's not getting enough dopamine. That rang a bell with somebody. Because it's common. Because there's just that misunderstanding that you forget that they need their medication to actually help them to move. And the tremor as well, the tremor can be affected by anxiety. That tremor, the tremor's worse, Elaine. And then it goes away when you calm them down, you're speaking to them. If it's a Parkinson's tremor, it will continue and it will be at rest. Okay? It's distinctive. But anxiety is a big issue with Parkinson's, and it does make the tremor worse. And any stressful situation they get into will make them worse. So the more stress you cause, the worse their Parkinson's will be. I'm putting this slide because there's more to Parkinson's than this motor mobility function. It affects the eating, even that coordination of getting it actually can maybe get so far, and the rigidity can cause eating problems as well. They can only get it so far, and maybe sometimes they just need a wee to get it further. But it needs to be encouraged. Eating problems with tremor as well can be difficult as well. Drooling. Anybody know why a Parkinson's patient has drooling? Exactly. We are sitting here automatically swallowing our saliva, or we'll be always sitting there drooling, because we automatically swallow our saliva. It's done for us. We sit and swallow our saliva and not think about it. We don't go, oh, swallow. It's done for us. In Parkinson's, that automatic function's gone. So they don't have that swallow. So you'll sometimes get drooling. Now, some people say, oh, Mr. Such and Such has got terrible drooling. Can we give him something for it? Now, there is things to dry up saliva. We can do. However, as Parkinson's specialists, we don't like it. Because usually in the care home situation, they're there because of cognitive impairment, because most of our patients end up in care homes due to cognition problems or dementia. And unfortunately, the patches and hyacinths causes confusion as well. So when I get a phone call saying they've suddenly gone off and they're more confused or they're hallucinating, if you take the wee patch from behind their ear off, you'll actually find that they'll get better. You know, okay, they're drooling, but at least the compos mentis a wee bit more. And that sometimes happens as well. So we tend not to treat it. What we do see is some strategies. Cold water helps stimulate the swallow, sometimes just with a sweetie. But most of all, the difficulty with that is, if there's drooling, it's the first sign that they're running into swallowing difficulties. And again, swallowing is a biggie in Parkinson's, especially when it comes to the complex advanced stages that you're dealing with. And again, it's the automatic swallow that we do. When we're eating, we automatically swallow, we automatically chew, and then we swallow. It's all multitasking. So something's got to go. And it's usually that safety second swallow and that catch before it goes either into the stomach or into the chest. So if you've got a Parkinson's patient who's continually having chest infections, it's a warning bell that they may be silently aspirating as well, because their saliva also trickles into their chest. Handwriting gets smaller. Fine movements, dexterity, buttons are difficult. Drop in blood pressure is notorious. As we get older, our blood pressure takes longer to catch up. It's an ageing factor, unfortunately. At 21, I could have bent down, picked up something, and not been dizzy. Now that I'm 22, I can't do it. Right? I kind of go, whoa, too much. So it's an ageing factor. But when you get Parkinson's, as you're standing up, what happens is your balance comes into play and your blood pressure catches up. But it's slower in Parkinson's, so you get the drop in the blood pressure. Then what we do is we treat the Parkinson's with drugs that cause the blood pressure to drop. So that's 3 whammies to somebody that's got Parkinson's. Age, the Parkinson's, and the treatment. So be slow with them. Sit the patient up and then stand them up. And when you're standing them up from a chair and they go, the balance has not been put into position, their blood pressure isn't correct, and you're trying to get them to walk. Or they're trying to do it. You just say, stop a wee minute. Everything's caught up. Now walk. So about Parkinson's, taking care of a Parkinson's patient, it's not, I'll get that done in 15 minutes. No. It takes longer with a Parkinson's patient. Depression's high in Parkinson's because where it affects the part of the brain is the mood centre as well. It's the feel-good factor, it's the basal ganglia of the brain, and the receptors there are the feel-good factor. And I don't know if anybody's read about some of the Parkinson's drugs that cause gambling, hypersexuality, anything like that. It's because of where the part of the brain is and the receptors are in the brain and the feel-good factors there as well. So the depression is quite high, anxiety is quite high as well. And what you'll find is that a patient will say, when I wake up in the morning, I'm going uphill, because they feel as if they're driving with a handbrake on. Everything, because the dopamine is not there, the accelerator isn't there, and the brakes are on. So a Parkinson's patient will wake up feeling as if I'm uphill, first thing as well. Sexual dysfunction is one of the, the key factors as well. Sweating, you might find your patients are sweating overnight. It's a difficult one to treat because it can be caused by the Parkinson's, but it can also be caused by the drugs. And it's a difficult one. Sleep, vivid dreams, one of the predisposing factors to having Parkinson's as well. And remember I'd said there's 4 stages, and now they're looking at what we call non-motor features is what we're looking at now, and that's the pre-diagnostic stage of Parkinson's. But if you go to your GP with any of these conditions, they're not going to diagnose Parkinson's. They'll just say either you're getting old, and that's it. But anybody has a predisposing factor like REM sleep disorder, where they're dreaming, or they're very vivid dreamers and know their dreams, that is a predisposing factor that it raises your chances of getting Parkinson's. Everybody panicking? Constipation is a biggie. Constipation, and in fact, we're going to actually start a wee study with our patients in Lanarkshire with Parkinson's. Why would you get constipated if you had Parkinson's? Yeah? Muscular movement, yeah, slowed down. So everything's slowed down, and therefore the water's taken out of the bowel and you get constipated. And then you get malabsorption of the drugs, so therefore their Parkinson's becomes worse. If you're actually elderly as well, constipation knocks them off anyway without Parkinson's, so that's a biggie as well. So be aware of your patients who have constipation with Parkinson's and keep their bowels regular as well. Incontinence, you get the neurological bladder, but you also get the poor mobility of getting to the toilet in time as well. Pain is a big issue in Parkinson's. People don't think that Parkinson's patients have pain. They do. If you're stiff and rigid, of course you're going to have pain. Muscle cramps are famous in people with Parkinson's as well. Difficult turning over in bed is multitasking. And if they say I have to sit up first and then turn, they're breaking down the task. And that's turning in bed, the simple act of turning in bed. Fatigue's a biggie, tremor done, falls and freezing, as you can imagine. Communication, low self-esteem in relationships, and yes, they get blood vision or double vision. The communication part is my biggie. When people that have heard me talk go, here she goes again. Communication, how do we communicate? Speak, words. Tone, gestures, yeah. Body language, would we agree? Yeah. So high percentage, if we broke that down to 100%, which part of that is more effective? How we communicate using words. Give me a percentage, somebody. 10. Tones and gestures. 70 body language. You're there, right? It's all about our body language, gestures, tone. What do Parkinson's patients lose? They lose the tone in the voice, they lose the body language, and also even the words they can lose, because the voice gets very quiet, because it's automatic that I'm speaking to you, forming sentences, doing all of that, and also projecting my voice. But the first thing to go on a patient with Parkinson's is the projection of the voice, because they're too busy thinking about putting the words together. So it's, and it's that very quiet voice. So it's very difficult when you're communicating with somebody with Parkinson's to get that feedback. And the best way I can say to you is, good morning. Good morning. It's different, isn't it? Because I've used different tones. But you'll get the same tone and the same thing for a Parkinson's patient. So when you're having a joke with the lady beside the gentleman who has Parkinson's, he's laughing at the joke. You just don't see it. So always remember that when you go in to see a patient with Parkinson's in a group setting, he's not miserable. He's actually wanting to participate. But it just takes him longer. And when you're communicating with a patient and you're wanting them to join in the group, what have you done? Yeah, because you're asking them to multitask in a group setting. So while everybody's having a wee yappy time and they're all talking about the dolphins, I know something about dolphins. And then it goes on to elephants, he's still at the dolphins. And when he wants to participate and say something about the dolphins, everybody's moved on. So I'll just stay in my roomie. And they become very socially isolated. So that's significant when you're communicating with somebody with Parkinson's. Extremely significant. And remember that. So one-to-one is better as well. One-to-one is better. And if you want them to join them in, sit one-to-one and let them know what's your opinion. And also the other thing is the 1 minute rule. It can take a patient or a client a minute to answer you back. So if you're going around the care home and say you're saying, do you want tea, coffee or juice? What have you done? Too many commands. Because you're asking them to retain it and then they're going, what was the first one? Oh, I'll get to him later. What do you want, Betty? And then he's still trying to go, tea. If you say to somebody that you go up and say, right, Mrs. Such and Such, get dressed, do this, do that, do that, and come out into the dining room. And then you go back in and they're going, I told you to. What have you done? Too much commands. One thing at a time. And give them time. Managing Parkinson's is through medication that we replace the dopamine. Surgery, we do deep brain stimulation. It has to be specific patients as well, and it's done at the Southern. Physiotherapy, speech and language therapy, occupational therapy are all important. And the reason they're all important is it's a bit like retraining, because you have to then think about each movement you do, getting up off a chair, how to transfer. It's all about retraining. Drug treatment. Basically, drug treatment is we're replacing the dopamine. That's what we're doing. We're replacing the dopamine. And the way we do that is by tablet forms. We can do is, anybody heard of Sinemet, Madapar, Stalevo? Yeah, somebody shouted out Stalevo there. That's levodopa, which is a synthetic form of dopamine. Now, if you're interested, Sinemet, you might see is 100/25 and say, why is there two drugs there? Well, the 100 is the levodopa. It's the dopamine that's the synthetic form of dopamine. That 25 drug is just holding it in the system so that more of it goes into the brain and crosses the blood-brain barrier. And that's the reason why there's two drugs. With Stalevo, there's a third drug, and that's called a COMT inhibitor. And Jessica should be doing this bit. That's a COMT, and it's just holding the drug so you're getting 100% of the levodopa into the brain. Right? So we use different types of drugs, and that's what we're doing. We're replacing the dopamine in the brain. Now, when a patient is diagnosed with Parkinson's and they start treatment, and they might have Sinemet 3 times a day. And then as gradually the disease progression happens, we might say 4 times a day, because remember, we're keeping replacing the dopamine. But as we keep replacing the dopamine and upping it, the drugs, there is a sensitivity to it, and therefore it's not as effective. So when it used to last 45 hours, it would only last 3 hours. And therefore we get into this complicated drug regime of having drugs every 3 hours. And that's another reason why a lot of our patients go into care, because they forget the drugs because there's cognitive impairment. But they forget the drugs. And what happens is then they need prompting. And sometimes they can be on 5 tablets, different times, and they need carers. And when it actually gets more complicated than that, it ends up that they end up in a care home because we can't get care in community for that much time. And that's when they'll end up either in a care home or there's a carer there and they're in for respite and they go into a care home. And they're specifically set times that they take them 3 hourly. And then it doesn't happen in the care home and respite. And then I'm called in when they're at home and they just totally, Parkinson's is all controlled and it gives me lots and lots of work to do. And the reason is they're not given the medication in time. And so it's important when a relative says they get it at 8, 12, 4 and 8, they get it at 8, 12, 4 and 8. It's important, extremely important. And how important it is how would you like somebody to control when you can switch on and switch off? So when you're waiting for those drugs, patiently waiting, and the nurse says in a minute, and you're slowly shutting down your body, how frightening would you feel? You're cruel. That's it. It's cruel. And it's frightening. Because you might not see them physically shut down, but all these non-motor stuff comes into play, the anxiety as well comes into play, and they get more anxious. So there's a reason why they're prescribed at certain times. And that's why. And also, if you've got a resident who gets up, you get up, help to dress, take them through, give them their breakfast, and then you give them the tablets. What have you done? I know there's at least 2 people in here that know the answer. You've asked them to move about, get dressed, move, swallow, and then you give them the tablet. What would be the best way to give them that? First thing when they wake up. First thing when they wake up. So that at least they've got some dopamine in their system so that they can help you to get themselves dressed and to get through into the dining room or whatever as well. So yes, the medication is important. You will get the odd Parkinson's patient, because everybody's different, that will take the medications whenever. But it might be that big umbrella of Parkinson's conditions that's different. But when a relative says they take it at A, B, C and D, that's when you give it. So we're replacing the dopamine, and that's what we're doing to help people move. And we're stimulating the nerve endings to go and do their job. Another way of treatment is we bypass that and we hit the neurons here. Dopamine comes here, we want to hit here, and that's called dopamine agonists. Anybody heard of them? Pinerol, pramipexole, rotigotine patch. Anybody heard in the news? Yeah, the Neutropro patch. Yeah, That's rotigotine, sorry, you're right. Anybody heard about people gambling on Parkinson's medication, spending money, hypersexuality? Nothing like that in the news? They're the main culprits, although it can happen in all Parkinson's medication. But they're the main culprits. So if you've got anybody that's on one of these drugs, and maybe there's been a change of behaviour that you've noticed, more sexual connotations or something more obsessive, have a wee look at the drugs, and then that's the time to say, I've noticed a change in behaviour, maybe give the Parkinson's nurse a call. Just so, because that's time to actually watch that and maybe actually withdraw some of their medication as well. And what it does is it tricks the brain to think it's got more dopamine than it has. But it also is one of the culprits for hallucinations as well. All Parkinson's medication can aggravate hallucinations and confusion, but these are one of the main culprits. So challenges when we're caring for somebody is it's great when they're diagnosed and you give them the tablets and they feel great. Everything's wonderful. Actually Parkinson's is not so bad. Everything's okay. These drugs are controlling my Parkinson's. As the disease progresses, we run into these fluctuations and the freezings that no drugs can help. And that's the difficult part. Because then, if they're out doing their shopping, they could get stuck in Asda's and not be able to move. So that's difficult. The wearing off, 4 hourly was fine. Then we went to 3 hourly. Then 2 hourly, it's a difficult one. There is advanced treatments where, I don't know if anybody's seen anybody with an apomorphine pump, which is a subcutaneous injection into the skin, and they carry the pump through their waking day. Anybody seen that? Yeah. And the reason we give that is what you're then doing is giving the treatment to kind of give an even flow throughout the day. And that's an advanced treatment. It's an injection every day, subcutaneous injection, kept in all day, and it does have its complications as well. Anybody heard of duodopa? No. I don't think I've got anybody in a care home. I've got a couple of patients in duodopa, and that is when a tube, like a peg tube, but it goes into the jejunum of the stomach, and then a pump's, again, been carried about, and it's straight levodopa into the jejunum of the stomach. It bypasses all the malabsorption issues, and it's supposed to give a more even flow so that you don't have wearing off. And that's another thing. But it's rare, it's quite advanced treatment, and it's by patient. You have to apply by patient to the health board because it costs a lot of money. Involuntary movements. Anybody seen anybody with dyskinesias? Involuntary movements with Parkinson's? It's not the Parkinson's, it's actually the side effects of the drugs. So what's happening is that you're getting them to move, and you reach that dopamine level, right? And remember, it's continuing to drop. But if you're continuing to drop and you're giving them the dopamine, it goes over that and makes it just too much, and they get too much movement, and they get what we call dyskinesias. Now, unfortunately, if we took away the drugs, that would happen. So the conversation we have with people is, do you prefer to be off and just, or do you prefer to be disconnected but able to move across the room? And usually it's dyskinetic as well. But also the fact is, when they're dyskinetic as well, what you've also got to remember, these drugs are stimulants and they feel good on it as well. Our heart sink is, as the disease progression, there's a high rate of dementia and Parkinson's. Now, the current figures are saying about 40%. It's a lot higher than that, And usually, as the disease progresses, and then they start to say to me, "Oh, Elaine, dreams, having nightmares, or hallucinations, wee spiders across the ground." Now, usually, if they're not too bad, we kind of say, right, but we know that it's going to go down. That's a wee signal for us to let us know we're going to run into neuropsychiatric difficulties. And we start to withdraw the drugs. And unfortunately, that is the difficult part. And that's where the physical disability starts as well. Because as we withdraw the drugs, because they're hallucinating, more confused, their functional ability becomes worse as well. And that's where the benefits out, the drugs are just not good enough because it causes so much side effects as well. So if you then give me a wee call and say, well, Mrs. Such and Such's mobility has gone downhill, and I come out and I say, well, how's she been cognitively? She's confused, doesn't know where she is, does she hallucinate? I say, well, that's fine, I'll give her more drugs to help her mobility, but were you quite happy to chase it down the corridor? Because the hallucinations will become so much worse and frightening. So then you'll say, that nurse was in and took away her drugs, and now she's worse. But mentally she's better. And that's the compromise, unfortunately, when the disease progression, with the disease progression as well. If you've got a patient that suddenly deteriorates like that, or suddenly develops hallucinations, are you going to call me? It's a progressive neurological condition. It doesn't happen suddenly. And if something happens suddenly, the culprits are dehydration, constipation, urinary tract infection, chest infection. And if you call me, I'll say, have you done all that and got the GP to check before I would come out? And then don't phone me until they've finished their antibiotics and then recovered, because it takes the elderly a longer while to recover, because I'll not change anything till all that dies down. Does that make sense? But if you call me and say to me, Elaine, this has been for a few weeks now and it's gradually escalating, that's progressive. And that's Parkinson's. Does that make sense? So if there is sudden changes, look for an underlying cause. So the key messages today are it affects everyone. It can change from hour to hour, day to day. Bugbear, medication timing. Don't stop the medication abruptly. Really a regular review by the specialists, and it's every 6 months. With the care home, it's mainly the nurses that do it, although some of the consultants will come out. Good, safe, stimulating environment. Exercise helps with the pain and the stiffness. Even chair exercises is good. And healthy diet. And there's my big sign to make sure timing of medication is really important. And there's my other big bear. Look beyond the mask of a Parkinson's patient and give them time. And that was perfect. Look at the time, 12 o'clock.